Okay, there is we have the slides there. Okay.
Recording in progress.
Okay, so I think this was a makeup or something, yeah? I had even forgotten about it. Thanks for reminding me. Classification of psychiatric disorders. And this is useful so that it helps you a bit more understand why we keep talking about syndromes rather than diseases as you would in other conditions. So our objective is to help you understand mainly the two systems of classifications which are currently in use, the common ones. That's the ICD and the DSM classifications of psychiatric disorders. Now, classification has been described as a process of reduction of complex phenomena into categories. It's a kind of the way you don't say, when you're told when you're going to buy fruits, you don't have to always write each one. You might say, to simplify, buy fruits. It covers a whole group of things. And so that is to reduce a group of objects into or phenomena. In this case, it's not even an object. Now, it is based, classification of disorders is usually based on pathophysiology. In medicine, you know the pathology, you know how the structure of the lung changes when you have pneumonia, you know how it changes when you have bronchitis, you know what bacteria are involved, and how it affects the function. This is the normal way of the usual way, not normal, of classifying diseases and disorders. But in psychiatry, we have that problem that we as yet don't have adequate knowledge of the biological basis. We know that neurotransmitters are involved. We even know some of the pathways where these neurotransmitters are involved, either too much production or too little deficient production. But we still don't know the exact changes. We don't have a way, simple ways of saying this one has a deficiency in dopamine. We have done a test and it is like this. So we mainly depend, we cannot really say that we're using biological basis for our diagnosis. We currently, until this is changing a lot, to the point where genomic studies are also indicating groups of genes which might be involved. But as of now, we are still at grouping the disorders together depending on syndromes, that is on the basis of certain shared phenomenological characteristics. So if A, B, and C have mental illness, and they have certain characteristics which they have in common, then we can say this is one group of disorders. They suffer from the same group of disorders. It is not because we have evidence based on biology or physiology, because even when they speak, we can say the characteristics of that speech are similar to this, but there's a lot of variation even then, and even in behavior. So you might find that one patient who has been diagnosed as having schizophrenia becomes mute and doesn't communicate with people. Another one is talking to themselves. Another one is talking to people but telling them things which are not understandable. So even when you take one form of characteristics like speech, you can only say that there are certain characteristics of speech that we have identified that go together with having such a condition. So in its own way, it makes it, of course, more difficult. And that is why we say sometimes you make a diagnosis and then you make a differential diagnosis, which giving us an allowance to change our diagnosis. Now, the reason why we classify mental disorders, ultimately, the whole idea is to improve on treatment and prevention. We want to improve on treatment and prevention of these conditions. And there are three main aims of communication, of classification. One is communication, the other one is control, and the other one is comprehension. And classification becomes a tool among users. This is not useful for non-users. Okay, I hope you understand that. That the tool that we're using may be only useful for people who are interested in mental disorders, but may not be useful for laboratory technicians, for example, or pathologists. So it is really for us to agree. And it becomes more useful if we have a high level of agreement. And that is why basically schools of thought agree that they come together and they agree, let us classify them in this way. And everybody who wants to follow that follows that. Another one we follow, but the level of agreement is not always 100%. So I must tell you that even as we are talking about DSM-5, there are many, many people who are very dissatisfied with it. There are those who are dissatisfied with ICD-11 and those who would like to see changes. So the degree of it, of agreement, may not always be 100%, but it is enough for people in different locations to talk about something and they know they're talking about the same thing. If I'm attending a conference virtually or in person in Australia, what I need to know when they say, what classification do you use? They say DSM-5, good. Then I know that when they say this patient had schizophrenia, then I know what kind of patient they are talking about. Of course, there is a lot of agreement between the two main systems of classification, the ICD-10, which we will look at today. It is not like they are divergent, so that if you go to the UK and they say schizophrenia, they mean anxiety. No, there is a lot of agreement in the classification globally. So when we use the name of categories, we summarize the clinical features, disease progress, prognosis, and treatment in a few words. If I'm talking to a colleague in Portugal, assuming I know Portuguese, and I tell them we have a case, we are presenting a case of patient with schizophrenia, it gives them already an idea of the presentation. It gives us an idea about how the disease will progress if not treated, or if treated, the prognosis, and what kind of treatment strategies. So we have a language. It gives us a common language. Okay, if you are a pathologist and you're talking about and we did a slide of the kidney, and this is what we found, then it is expected that there's very little dispute anywhere, okay, about it. It is very clear, it's objective. Several pathologists will come and say the same thing. This may not always be true of psychiatry, okay? There is a certain element of subjectivity. Now, when we talk about control, we are talking about the ability to control, prevent the occurrence or the modification of the course of treatment. Based on that classification, we have some idea about how the disease will progress. And then when we talk about comprehension, we are talking about trying to comprehend the causes of mental disorders and the process involved in their development and maintenance. And this becomes very, very useful when you have common language that you can use, because then you know if it is this one, you know that again, you know what to expect. So basically that is it. Now, a little bit on the historical background. there is nothing new about mental illness. Mental illness is as old as human history. We don't know whether the Stone Age people or the Neanderthaler or the Cro-Magnon had mental illness. Of course, we don't know very many things about them either. Sometimes it's a very interesting, like, I think when somebody looks at the bone, the calcified bones of a Cro-Magnon, like I think Lucy or something, and then they say that it is from this, it is possible that this person in quotes died of liver failure, or this because of, we see it in their deposits on the bone or something like that. This is something you cannot say about mental illness. There is no excavation that you can do that will tell you whether a person died of schizophrenia. Even if you do this excavation 10 years later, leave alone 1 million years later. So, but we still do have documentation. The first documented description of mental illness, and I say documented in that it is documented, goes as far back as 3000 BC in ancient Egypt, the Sumerians, and the Hindu writings. And we do know, of course, that documentation and writing originated from these ancient civilizations. So we expect that if there's going to be documentation, that's where it's going to come from. Greek, you all know this figure, Hippocrates, a Greek who lived between 460 to 370 BC, and is usually regarded as the father of modern Western medicine. Not all medicine. Eastern medicine had its own followers, but Western medicine, and this is the person who also is has been ascribed to having written or talked about the Hippocratic Oath, which is still taken by doctors around the world. Of course, they do take the more modern one, where they don't refer to this God and that God. Look at both of them anyway and see. So he introduced the first concept of psychiatry illness in medicine. And he described acute mental disturbances with fever, which we now often refer to as delirium. He also talked about acute mental disturbances without fever and chronic mental disturbances without fever. And these two categories are the ones that have been of great concern to psychiatry ever since. While we leave the deliriums mainly to our colleagues in the physicians. Now, there's a guy who was called Philippe Pinel, a Frenchman, who is also has made a revolution in the treatment of mental illness. He's said to have been the person who removed the chains from the mentally ill in France, in Paris, in the huge hospital in Paris, where mentally ill patients were chained. And so he introduced the concept of the humane treatment of mental illness. Philippe Pinel recognized 4 fundamental clinical types. He talked about mania, which we still talk about as part of the bipolar syndrome, melancholia, which is a word which has kind of no longer in use, but which has been, you'll find in many textbooks as severe depressive illness. Melancholy, the word comes from the word melancholy. Dementia, he talked about dementia, and he talked about idiotism, okay, which covered the whole range of disorders from intellectual impairment to schizophrenia. Then in we have Kriplin, who 1856 to 1926, Emil Kriplin talked about mental illness as being organic entities that could be classified on the basis of knowledge about their causes. I don't know how to pronounce the difference between the cause and the cause and the outcomes. And Emil Kriplin said that there is an organic. If you look at the history of psychiatry, you know that particularly in the times before Hippocrates, mental illness was regarded as belonging, and even long after, in the spiritual sector. And you got mentally ill, they called for the priest or somebody to come and look at the kind of demons you were carrying. Anyway, he talked about organicity, although we are still struggling to establish this organicity. He recognized manic and depressive disturbances as two faces of the same disorder, and also characterized by relapses and remissions, which we know even today. Manic depressive psychosis is what we now call bipolar disorder. It has one pole as manic and the other as depressive, and can have in between remissions where the person is completely functional and normal even without treatment. Then he talked about chronic deteriorating illness called dementia precox. And he said dementia precox has one form of distinct form, which was paranoid, characterized by paranoia. He also introduced the concept of psychogenic, what is called psychogenic neurosis, which we don't use the term neurosis anymore, also partly because it's a term which was highly abused in layman's language. Stop being neurotic, So we have stopped using that term. And then he also talked about something else which we still talk about, and that is personality disorders. He talked about the psychopathic, specifically, who we call sociopaths. Then Eugen Bleuler later renamed dementia precox to what it's called today as schizophrenia or split mind. So the emphasis again here is that in the absence of clear biological etiological causes, most of the disorders or diseases diagnosed, we prefer to call them disorders, are syndromes. It's a collection of symptoms that tend to appear together and seem to have a characteristic cause and outcome. So again, our limitation in diagnosis is that we are not able to show the organicity or to have a laboratory test that we can use that will tell you for sure that this patient is suffering not from schizophrenia, but from bipolar, or not from, or to even show, which has been a big question always, is schizophrenia one disorder, or is it separate disorders? Because the diversity in which it presents, like you have some with paranoid, somebody with only negative symptoms, with only positive. Are these is it a group of disorders which have an overlap in the terms of behavior and thinking, or are they different? And the only time we'll be able to do that is when we can definitively show the structural changes, or not structure, even biochemical, and be able to show that in this type, this is what is happening at this part of the brain exactly. And in this one, then we'll be able to say, aha, these are two different conditions. So we are still talking about syndromes. So I mentioned we have two modern classifications systems. The International Classification of Diseases, ICD-10, I think now it's ICD-11. This one is produced by the World Health Organization. And then we have the Diagnostic Statistical Manual of Mental Disorders called DSM, which is currently at DSM-5. Started at DSM-1, 2, 3, 4. 2 years ago, we were still at 4. Now we are at 5. And this is produced by the American Psychiatric Association. Now, a little bit about the ICD. The ICD, the International Classification of Diagnosis, is not just for mental illness. It is for all conditions, for all diseases, variety of health conditions, okay? And the ICD-10 specifically states that mental disorder is not an exact term, although it's generally used, okay, as an exact term. It is a term that implies the existence of a clinical recognizable set of symptoms or behavior associated in most cases with distress and with interference with personal functions. So it's not quite exact. And again, for the same reason, the lack of biological evidence. So these are the mental and behavioral disorders that the ICD-10. They start with FO. Of course, important also, and the reason why they have coding is for insurance purposes as well. In a lot of the Western countries, if you're claiming, if you're claiming from the insurance, the treating doctors have to indicate the code. We hardly ever use the codes ourselves because our insurance companies don't require that you give a code. So FO, when you see this FO, F1, those are just the codes. So organic, including symptomatic mental disorders, that is disorders where there's evidence of organicity, either due to a known physiological condition related to it, or temporal association, or laboratory evidence. And then in F1, you have mental and behavioral disorders due to the use of psychoactive substances. I don't have to explain that. Then you have schizophrenia, comes under F2. Schizophrenia, schizotypal, and delusional disorder. Again, you'll see that in the DSM, this is very, very close. So that the only thing they don't have is some things that we call in the DSM schizophreniform, and another which we call schizoaffective, which is a controversial diagnosis anyway, even now. Then they have the mood disorders, mood as in affect, change in affect, disorders in which it's mainly the affect that is affected, impaired. Well, that includes depression, bipolar, or what we call manic depressive used to be. Then they still use the neurotic stress-related and somatoform disorder, which was dropped by the DSM criteria. Behavioral syndromes associated with physiological disturbances and physical factors. Then they have disorders of personality and behavior in adult persons. Then they have mental retardation, disorders of psychological development, which are usually seen in childhood or start in childhood. Then they have behavioral and emotional disorders with onset, usually occurring in childhood and adolescence. Then they have what they call a group of unspecified. That gives you room for wiggle. So the DSM-4, let me just mention, the DSM-4 had a very interesting way of classifying mental condition, which was a lot criticized because it differentiated. They said, oh, this sets mental illnesses apart from physical illnesses. Because if you make a diagnosis of pneumonia, you just make a diagnosis of pneumonia. You don't say axis 1, axis 2, axis 3, axis 4. But which was very, I always found very useful Okay, maybe that's the one I grew up with, because it helped to remind you that mental illness affects many areas, many dimensions, many areas of our lives. So it had an axis one, which was the clinical disorder, except personality. And then axis two had personality disorders and mental retardation. That means you had a clinical disorder and then you went to axis two. Does this person also have a personality disorder or mental retardation? Then it had an axis three, which looked at general medical conditions, but only those which are connected to a mental disorder. For example, if you did an axis one diagnosis of generalized anxiety disorder, and then personality disorder, you said there was nothing, then you found that this person had asthma. And we do know that asthma is associated with anxiety. Then we would put an asthma there. Then we had an axis four, which helped us to look at the psychosocial and the environmental problems which were associated with the disorder in axis one. For example, that this person has limited social support. That's important. Or this person has been jobless for a long time. And then there's something they call the global assessment of functioning, which tried to see, to work on the severity of the conditions, continuum between mental health and extreme mental disorder. So they try to categorize how severely ill were you by giving you a score, a GAF score. Now we've dropped the DSM-4 and now we are teaching DSM-5. In sort of, we do have a tradition in our department for many years now. Before we used to do ICD-10, but then we moved off, and for some reason, which I don't know, I wasn't there, we moved over to the DSM as the standard diagnostic criteria that we use. So in most parts of in Kenya, you'll find that most of the people, when they make the diagnosis in psychiatry, they'll be making a diagnosis based on the DSM-5 or 4. So the DSM-5 was published in 2013. It took us about 4 or 5 years before we started teaching it. And right at the moment, we have stopped teaching DSM-4. So I'll give you a quick rundown of the disorders of DSM-5, some of which we may have talked about. And the first group of disorders is the neurodevelopmental disorders. So these in DSM-4 used to be called disorders occurring first in childhood. Now we call them neurodevelopmental disorders. We talk about intellectual disability, communication disorders, autism spectrum disorders, which means it's a group of presentations. So we call them autism spectrum disorders. Then we have attention deficit and hyperactivity disorder, specific learning disorders, motor disorders, and other neurodevelopmental disorders. So that is your first category. And then we come to the schizophrenia. Again, like we've been emphasizing, schizophrenia is very, very important disorder. And the importance of schizophrenia is not because it is very prevalent. It is because of the devastation that it causes to the person, the community, the family. It is a very devastating condition. So we insist that if you want to change the person's life, you must be able to diagnose it early and treat it early. Also, because the treatment outcomes depend on early diagnosis and treatment. The longer you stay, the more difficult it gets to treat. So these are the disorders that are now classified. Schizotypal, it is a personality disorder, characterized as a personality disorder, but it's kind of so impairs function that it has been pulled out from the personality and put under the psychotic disorders. It is these strange ways of thinking, beliefs, which impair functioning. So it is now considered part of the psychotic, schizophrenic spectrum disorders, delusional disorders, pre-psychotic disorder, schizophreniform, which you will not find in the ICD 10, but maybe a brief psychotic is there somewhere, maybe in 11. Then schizophrenia, schizoaffective, substance or medication-induced psychotic disorder, and psychotic disorder due to another medical condition. I think when I was presenting to the small group about the ones who are rotating in psychiatric now, we talked about the core symptoms of a psychotic disorder. Catatonia. Now, this is a tricky one. This used to be classified as a type of schizophrenia, but it was found that the symptoms we are talking about can appear in schizophrenia. They can occur in substance use disorders. They can occur in major depressive disorders. And so it became what we call a specifier. So it became what we call catatonia specifier. That means you can make the diagnosis of catatonia as a specifier, for example, for schizophrenia, or due to major depressive disorder, catatonia associated with, confusing, catatonic disorder due to another medical condition, of course, then the unspecified. So the catatonias where you cannot place, you don't know, is it, does this person have in the background schizophrenia, major depressive or another? You don't know. You can't get it. Then you just leave it as unspecified catatonia. Then other specified schizophrenia spectrum and other psychotic disorders. Then you have unspecified schizophrenia spectrum and other psychotic disorder. So this ends the schizophrenia. Again, and other psychotic disorders. We give ourselves a leeway to have a disorder which doesn't fit into a schizophrenia spectrum, doesn't fit in schizophrenia, doesn't quite qualify as schizophrenia or schizotype or schizophreniform. And so we put it as unspecified, but usually this is usually short-lived. And with time, people are able to revise the diagnosis and put this unspecified into one of the other schizophrenia spectrum disorders. Then you have the bipolars. They have bipolar 1, bipolar 2, cyclothymic, which just has to do with the change of mood, very rapid cycling of mood, substance medication-induced bipolar, bipolar related due to another medical condition, and other specified bipolar. Again, room to wiggle with other and unspecified. Then we have the depressive disorders, including the disruptive mood dysregulation disorder, major depressive disorder, single and recurrent persistent depressive disorder, which used to be dysthymia, premenstrual dysphoric disorder, substance medication-induced depressive disorder, and so on. I was just running through the actual categories, but you will be able to cover, I think you've probably covered some of these individually. And then you have your anxiety disorders, which again run from separation, selective mutism. Separation anxiety disorder previously used to come under disorders appearing in childhood, but has now been put into the anxiety disorders. I don't have to read everything. Then the obsessive compulsive and related disorders, which include OCD, body dysmorphic disorder, hoarding. Hoarding disorder is a relatively new disorder. It is also sometimes you'll find it, people with hoarding disorders referred to as messes because they collect so much stuff that, trichotillomania used to be under disorders occurring in childhood, skin picking as well. Then the other one is substance induced and related to another medical condition. Then trauma and stressor related disorders. This is how changes occur. PTSD or reactive attachment disorder used to appear in DSM-4 in childhood. Disinhibited social engagement disorder was not even there. Post-traumatic stress disorder used to be classified under anxiety disorders. So, but with this new classification, these disorders now fall under trauma and stressor-related disorders. Then there's the dissociative disorders, which we were talking about today. So we don't have to go into that. Then you have your somatic symptom and related disorder. That is disorders which have an element of somatization. And something that we used to call hypochondriasis, you will not see it in DSM-5 because it's now called illness anxiety disorder. Conversion disorder, which is also called functional neurological symptom disorder, because it usually must have a neurological symptom, paralysis, blindness, I don't know what. Psychological factors affecting other. Then there's the interesting ones, the factitious ones. Then you have your feeding and eating disorders. Some of them, like pica, used to occur only in childhood before, but has been brought here. And important in our setting, not so much. We don't see a lot of course, pica in childhood, but usually commonly associated with intellectual disabilities. But some of these avoidant restrictive food intake disorders, the anorexia nervosa and bulimias and so on, they're not very common in our setting. Then you have the elimination disorders, which again used to occur are the disorders that first appear in childhood, enuresis and corporesis, and the other specified. Then you have the sleep disorders. Somebody was asking whether there's dissociative disorder in sleep. No. Then you have sleep disorders. You have insomnia, hypersomnolence, narcolepsy. Then you have this obstructive breathing related, like obstructive sleep apnea, central sleep apnea, and so on. Then you have, I think that one would occur under sleepwalking, sleep terrors, nightmare disorders. This is where some of those, maybe you think dissociation, but it's not dissociation because the person is asleep. Then you have your sexual dysfunctions, again, will be covered under sexual dysfunctions. Nothing much has changed except that they have put a male and female separate ones. Then they have gender dysphoria. Again, that has kind of changed a bit from DSM-4. It used to be called gender identity disorder. Now it's called gender dysphoria. And then there's this other conditions which also used to be classified as childhood disorders: the disruptive impulse control and conduct disorder, oppositional defiant disorder, intermittent explosive disorder, conduct disorder, and they have put antisocial personality disorder here. It used to be under personality disorders. Then they have put this very pyromania, kleptomania. Don't start wondering whether all the school children these days have become pyromanic because they are burning schools. No. We cannot make that diagnosis as a group diagnosis. It is usually an individualized one. Then we have our substance related and addictive disorders. You have substance-related, substance use, substance-induced, intoxication, and withdrawal. So the substance-related disorders are further grouped into the different category of substances, ranging from alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, stimulants, tobacco, and lastly, no, not lastly, I thought that was the last, the non-substance related disorders like gambling disorder, which has become a big problem in our country. Used to be not such a big problem. Now it's becoming a problem. Neurocognitive disorders, that's the delirium and the major and mild neurocognitive disorders. Now, we still have the personality disorders, and these are cluster A, B, and C, and then the others, which are not specified. And this is cluster A, paranoid personality, schizoid personality, schizotypal personality, which I mentioned has also moved to be part of another group of psychosis. Cluster Bs, this used to be antisocial, used to be here. Now you've seen it's in another place. The borderline, histrionic, narcissistic, avoidant, dependent, and obsessive compulsive. It's something I need to check because, okay. Paraphilic disorders, I think I may have to, there's something I need to check about these disorders which moved into other places. Maybe I used an old table. I need to check that. Paraphilic disorders, voyeurism, exhibitionism, these are all disorders which again you will do. They used to fall under sexual disorders, but now they have their own category because they are kind of like different forms of expression of sexuality. Then, just to be on the safe side, we have other mental disorders, just other unspecified mental disorders due to another medical condition, other specified mental, unspecified medical induced, and just to cover some of those things which are like catch-about syndromes, which you may have heard about, other conditions that may be a focus of clinical attention. So we don't have a culture-bound syndrome as a category. They now fall under, they are recognized, but they fall under other conditions that may be a focus of clinical attention. Oh, good. Now I'm done. Sorry, I ran through it a bit quickly. But I guess the whole idea is to give you an overview of classification, but as to the different categories, you will have to, they are part of the lecture schedule. All these disorders, you learn them under different schedules. Again, remember that we give ourselves wiggle room by saying other or unspecified, not specified, unspecified. And this allows us also, we also give ourselves room to change, to revise the diagnosis. And that is why we like to have differential diagnosis. And I think I have justified why we do that. Any questions? If there are any questions, please put them on the chat. We have a few minutes and I'm giving you 5 minutes to put your questions on the chat. Don't ask me about, okay, let me not ask you, tell you what not to ask me. Just ask me and then I will see. As long as it's not about the current genomic studies, which is advancing as the human genome is being studied, but it was a very hopeful way of studying, but the current situation is more or less like they're finding that it is not just one gene. You cannot just identify one gene for schizophrenia, for example, but there are multiple genes at play, which means that the environmental and social factors still play a major role in the appearance of mental illness. Elimination disorders are disorders associated with inability to control urine or feces. That is what they are. Usually find them in childhood, like enuresis, onchoporesis. I hope that explains it. Any other questions? I'll send the 2 lectures today to your class rep. If there are no other questions, then you will allow me to depart, and I'll send you the notes. Good evening to you all. How big a role does dopamine play in these disorders? Schizophrenia. The dopamine does play a major role, has been known, what we call the dopamine theory of schizophrenia, has been known to play a major role in the development of schizophrenia specifically. With the major depressive disorders, the bipolar, it is other neurotransmitters, the serotonins, which have been implicated.
Thank you, Professor Mathai.
Okay, fine, bye.
Bye-bye.
Recording stopped.